Written and the verbal admonishments and orders. We'll take a break until 10 minutes after the hour, at which time we'll buzz you out. So we'll see you at 3:10 p.m. Thank you. In the case of People versus Conrad Murray, the defendant, Dr. Murray, is present with his counsel as before. The people by their counsel as before. Dr. Kamangar, once again, is on the witness stand. All 12 jurors and the 5 alternates are present. Good afternoon to everybody again. Dr. Kamangar, good afternoon again, sir.
Good afternoon.
You acknowledge you are still under oath and still sworn to tell the truth?
Yes, sir.
Thank you. This would be a resumption of direct examination by the people. Mr. Walgren.
Thank you, Your Honor.
You're welcome.
Doctor, I wanted to ask you about the significance of the timing of the 911 call that you have testified about, regarding an extreme and unconscionable violation of the standard of care. I want you to assume that Dr. Murray found Mr. Jackson at about noon in the condition he described in the interview statement you've read. And let's assume then he was found at noon, and you've also read the interview statement where Dr. Murray called Michael Amir Williams and indicated he did not want to ask Michael Amir Williams to call 911. Do you know to what I'm referring?
Correct.
So I want you to assume that he finds Michael Jackson, let's just say, for the sake of argument, at noon, and makes that call to Michael Amir Williams at 12:12 p.m. As someone in critical care specialist and knowledge in this field, what is the significance of that 12 minutes from the time of finding Mr. Jackson to calling Michael Amir Williams when he could have obviously instead called 911?
I think the greatest significance in this scenario, having cared for many patients in this similar situations, is really the lack of blood flow to the vital organs. And the most vital organ when somebody is in cardiac arrest or cardiopulmonary arrest is the brain. And the brain is very sensitive to that lack of blood flow. And the longer the brain is without adequate perfusion, adequate blood, and with it oxygen, the more likely that individual is to have a deleterious effect from the lack of oxygen. Now, that is variable in different individuals, and some individuals are more susceptible to the lack of oxygen than others. But certainly beyond a period of 4 to 5 minutes is really when brain cells begin to die, when there is inadequate perfusion to the brain. And these are really kind of the golden minutes that is essential to really maintain that blood flow until a more definitive help arrives and there is restoration of circulation. So it is very critical, and the most immediate jeopardy is the higher part of the brain called the cerebral hemispheres. Now, I'm not a neurologist, but this is something we see all the time, is patients that are found, within a shorter period of time. Sometimes it's the higher part of the brain, the hemispheres, that make us who we are, allow us to coordinate motions, allow us to speak, allow us to have feelings. That is the part of the brain that is usually affected first. And sometimes people initially that are in that state, they're in what we call a comatose state, where they're unresponsive, and then over time, if their body survives, if they survive that initial period, usually 3 to 4 weeks, then at times they progress to this state of persistent vegetative state that we also unfortunately see, and that is obviously devastating in its own right. But certainly if there's even longer periods of lack of blood flow to the brain, the more vital part of the brain that is responsible for basic bodily functions like maintaining a blood pressure or breathing, the brain stem gets affected, and then that is incompatible with life. So certainly the longer there is lack of perfusion to the brain, the more significant the sequelae, meaning the worse the outcome. And certainly time is really of the essence.
Okay, and you said specifically beyond 4 to 5 minutes, the brain cells start to die. Is that accurate?
Right. There is variability. We
Sure.
see this all the time with different individuals. Not everybody fits the same mold, but certainly beyond 5 minutes, I think it can be quite devastating if there is really no circulation or effective CPR during, beyond that 5-minute period.
And in a way, that's almost the best case scenario. That's assuming you don't die.
That's correct. That's correct. And again, that's the variability that every person is different. And that is really kind of the art of medicine. There's not, everybody fits a certain rule. Some people are, you're right, more sensitive to that and can die earlier. Absolutely.
And then going then from 12 o'clock to when Dr. Murray calls Michael Amir at 12:12, I want you to assume, and if you know from the records you reviewed, that 911 was called at 12:20. So now from the assumed time that Dr. Murray found the patient, it's 20 minutes till the time that 911 is called. What is the significance of that?
Well, that just compounds the underlying effect of lack of adequate circulation and adequate oxygen to the brain, or the anoxia, lack of oxygen again to the brain, that is really, really critical. And I think at that point it really becomes irreversible. I mean, you reach a point where even if you are otherwise healthy and young, it becomes impossible.
Thank you. Now, you also, in your report, document and conclude that Murray deceived the paramedics by withholding key information about the propofol. And go on to say he also deceived the medical staff at UCLA about the propofol. You describe that deception as unconscionable and extreme violation of the standard of care. Can you explain your reasoning and your findings in that regard?
It is, essential to provide every element of a patient's history, and particularly in this situation, to really exclude the use of probably, most definitely the strongest agent, the strongest sedative here, was really unconscionable. By providing all the history, the medical personnel, whether it's the paramedic and later the emergency staff, are able to really focus in on the problem as opposed to trying to eliminate others. It really allows them, it provides them with critical information that is there. And when you have that information and you're not giving it, you are really doing wrong by really one of the basic principles of medicine, of just first putting your patient first.
Now, as a board-certified expert in sleep medicine, did you also then analyze the facts as you understand them to be in this case from a sleep medicine perspective?
That's correct, I did.
And you discuss initially that there's no indication that Dr. Murray performed an appropriate diagnostic evaluation of Mr. Jackson's insomnia. What is a diagnostic evaluation of insomnia?
I think the most key part is a detailed history. Insomnia is a problem that very often is secondary. It's comorbid. It's associated with other problems. Namely, it's associated with underlying medical disease, underlying psychiatric or psychological disease, substance abuse or medication history, as well as certain sleep disorders in and of themselves can cause insomnia. So the most important part of evaluating a patient with insomnia is to get a detailed history, to really have a comprehensive assessment of any underlying medical problems, to potentially rule out any medications or any substance abuse problems that could be causing. I mean, these could be very simple as just caffeine intake or stimulants. Patients that are on methamphetamines, for example, for sometimes treatment of underlying disorders. It is imperative to first rule out these secondary causes because they are so prevalent, and insomnia is a very prevalent condition. So our duty is always first to exclude secondary causes before we perhaps label someone as having primary insomnia, which is when you've excluded all the secondary causes, like I mentioned, the medical problem, psychiatric problem, medications, and sleep disorders that can result in the insomnia itself.
Can you educate us a bit on insomnia? The different types of insomnia? You mentioned primary insomnia.
Right. I mean, it's
No, please, if you could just give us kind of an overview,
Sure.
A general understanding of insomnia.
Sure. Insomnia is really defined as of difficulty with sleep or unrestful sleep over a period of 4 weeks or longer. That is further broken down into patterns of insomnia, which are just variations that can occur with different types of insomnia, which are people that have problems with what we call sleep onset insomnia, where they just don't fall asleep. The problem is actually falling asleep. So they have a long time between when they go to bed and when they fall asleep. There's sleep problems with sleep maintenance insomnia, people that just go to sleep but keep waking up, so they have multiple awakenings and cannot maintain sleep. There are people that wake up early from sleep and then cannot go back to sleep. We see that sometimes in elderly individuals, more of a circadian problem, because their circadian clock, the part of their brain that tells them to wake up, they're the early risers, we call. So there are these patterns, but then once we go down and we kind of dissect insomnia, really we break it down into secondary insomnia, which is due to underlying conditions that we just talked about. And once we've ruled out those underlying conditions or medications or even environmental factors, someone is just sleeping in a room that's always lit. We talked about the intensive care unit is not lacking the proper kind of environmental disposition for good sleep. So environmental factors, medications, medical illnesses, sleep disorders, psychiatric problems. Once you've ruled all those out, then we usually refer to it as primary insomnia. So as you can imagine, the history, medication use, psychiatric history is pivotal. I mean, a lot of time is spent just to figure that out.
And then in pursuit of this complete diagnostic evaluation, I assume this ties in with the medical records again, that this would all be documented and charted and for future use?
Correct. I mean, that is part of the initial evaluation where you do an initial assessment or history and physical that's really geared towards the underlying problem, and it would really go over not only the positives, the pertinent positive, the conditions that the patient may have that may be resulting in the insomnia, but also pertinent negatives, things that you've excluded as well that are important to note.
Now, you include in the diagnostic evaluation that you need to take a detailed sleep history. What is that?
Yeah, it's quite basic. It is asking the patients about just patterns of sleep. When do they go to sleep? When do they go to bed? Versus what time do they fall asleep? How many times in the middle of the night do you wake up? What time do you wake up in the morning? What medications and drugs that may be involved are also as part of that history that we talked about. A sleep diary or a sleep log where we give them patients a log where they actually fill out a week by week, kind of night by night log of when they go to bed. Once they go to bed, how long it takes them to fall asleep. When do they have their awakenings? When do they wake up? Is very clear. It allows us to kind of look at this trend and say, well, this is the problem. This is what's going on. It really helps in the diagnosis by following that trend. Whether